In this video, we're going to be talking about drugs or medications that work against Mrsa or MRSA. Mrsa stands for methicillin-resistant Staph aureus. It's a type of bacteria that can cause several types of infections, such as skin and soft tissue infections, which include cellulitis or infection of a certain part of the skin. It can cause bacteremia or infection of the bloodstream. It can cause pneumonia, a lung infection. It can cause endocarditis, an infection of a certain part of the heart, and more types of conditions. Now, Staph aureus is a very common type of bacteria. What it means by methicillin resistant is that it's a type of Staph aureus where certain medications don't work, such as penicillins, which include oxacillin and nafcillin, and most cephalosporin medications, such as IV ceftaroline, they don't work for MRSA. They can work for methicillin-sensitive Staph aureus or MSSA, but not MRSA. So the point of this video is to just present a mnemonic that you can use to easily memorize the main types of medications that work against Mrsa. This is just a very bare bones 30,000 foot view. For some of these medications, it depends on where you work. In your hospital or in your clinic setting, your pharmacist might have different guidelines as to what types of medications to use, so just keep all of that in mind. So the mnemonic that I made up to cover Mrsa drugs, they are line to dab in the clean pristine van, tiger and dog covered in tons of tar. So realistically, nobody would make a line to dab in a van. A tiger and dog together would probably never be covered in tons of tar, but these are just some mnemonics that I made up and hopefully they help. So line stands for linezolid, dab stands for daptomycin, clean stands for clindamycin, pristine stands for quinapristine/dalfapristine. This is like a new combination of Mrsa drugs that act on the 50S ribosome. They may not be available depending on where you work. Van stands for vancomycin. Vancomycin is the main type. It's the number one medication that you use to treat MRSA. For MRSA, you always use IV vancomycin. You don't use PO vancomycin, doesn't have good penetration. For PO vancomycin, that's what you use to treat C. diff infections, but for Mrsa, you use IV vancomycin. Tiger stands for tigecycline, dog stands for doxycycline, tons. The T and the S are capitalized because they stand for trimethoprim sulfamethoxazole or TMP-SMX. The brand name is Bactrim. And TAR stands for Ceftaroline. Ceftaroline, I should say. Ceftaroline is a 5th generation cephalosporin. It's pretty much the only cephalosporin that works against Mrsa drugs, because most, like Keflex or cefazolin, amongst other ones, don't work against MRSA. So I mentioned that vancomycin is the number one medication you use. So depending on the drug susceptibility and the antibiogram at your clinical institution, you might have a Mrsa infection that's vancomycin sensitive. That's good because vancomycin is the number one. But what if you have a vancomycin resistant MRSA, which is something that's an unfortunate reality in this day and age where antibiotic resistance is becoming more and more common? In that case, you have linezolid. Linezolid is your number 2 and vancomycin is your number 1. The good thing about linezolid is you can give it IV, but you can also give it PO or orally. So if you want to discharge a patient on something oral, you can give them linezolid. You cannot discharge them on vancomycin orally because that's only for C. diff, not for Mrsa. So we talked about the medications. Hopefully this mnemonic helps, but I just wanted to mention some of the major side effects of each of these medications to keep them in mind. Okay, and again, this is just a bare bones 30,000 foot view. There are many more side effects with these medications, so just keep all that in mind, and your friendly pharmacist at the institution where you work should have more information about these side effects and also what medications they prefer to use. Just keep in mind, in most institutions, vancomycin is the number 1, followed by linezolid at number 2. Okay? So, some side effects of linezolid. So this happy face represents something called serotonin syndrome. Serotonin syndrome is a condition where you have too many serotonergic drugs in your system. So for example, let's say you are on an SSRI like fluoxetine or paroxetine, and then you take tramadol, and let's say you take linezolid as well. Combining all of these medications increases your risk of having serotonin syndrome. You can have fever, clonus. It's more of a neurological side effect, and you can treat it with something called cyproheptadine. Okay? Another side effect of linezolid is you have low platelets, and then another side effect is optic and peripheral, and this is a nerve cell that I tried to draw, neuropathy. So you can have optic neuropathy, and then you can see that on an ophthalmoscope in terms of your optic nerve being damaged. This is normally reversible if you stop linezolid. And then peripheral neuropathy, that's more like numbness and tingling, for example, in your hands and toes. And for peripheral neuropathy, unfortunately, it is not as reversible. It's typically irreversible, even if you stop linezolid. Okay? Daptomycin. For daptomycin, you do not use it to treat Mrsa pneumonia. For Mrsa pneumonia, just FYI, it's a very serious pneumonia, and you can have kind of like a cannonball nodules that appear on a chest x-ray. Patients are typically pretty sick with Mrsa pneumonia. It tends to affect older people and also immunocompromised people, so people with HIV/AIDS, people who have gotten organ transplants in the past. Keep Mrsa pneumonia in mind, especially if you see lots of cannonball nodules in a patient with pneumonia. So you avoid daptomycin in Mrsa pneumonia because the lungs have surfactant, and surfactant inhibits daptomycin, so daptomycin can't work. This little sign stands for inhibit. Okay? Clindamycin. Clindamycin is a medication that's not used as much because it does have an increased risk of C. diff. So just imagine you treat a patient's Mrsa and then they get C. diff. Very unfortunate. But then you can treat it with PO vancomycin, but then vancomycin also has its side effects. So in most cases, people tend to try and stay away from clindamycin. Okay? And then quinapristine/dalfapristine, again, this is a new class of medications. It acts on the 50S ribosome, and it can also cause C. diff, and it can cause increased bilirubin. So the increased bilirubin might present as yellowing or jaundice of the skin or eyes. Okay? And then you have vancomycin, our number one medication. So vancomycin also has several side effects that are often tested on your medicine boards. So one, for example, you can have a drug-induced fever. So let's say you give somebody vancomycin, and then a few hours later they start to spike a fever. You might be thinking, oh no, do they have a new infection? Was vancomycin not enough? It's a possibility. Or it could be a vancomycin-induced fever. Another thing is, I tried to draw an eye and a kidney here. It is auto and nephrotoxic. So let's say you start a patient on vancomycin, they start having vision problems. Or their creatinine starts bumping up, and then that could be a sign of nephrotoxicity. Another thing with vancomycin is you can have red man syndrome. It's basically an IgE or histamine-mediated reaction. You start vancomycin and their skin just turns red. And then another side effect is thrombophlebitis. So for thrombophlebitis, that's you give vancomycin and then their blood vessels start popping out. That's another side effect of vancomycin. And then you have tigecycline. For tigecycline, these brackets stand for concentration, meaning low plasma concentration. Meaning if you give tigecycline, sometimes the concentration in the blood might not be as much as you want it to be. It's relatively low, so you typically don't use this to treat a bacteremia. And then we have doxycycline. This is just like a photo of like a palm tree and a sun on a beach that I tried to draw. Photosensitive. So for doxycycline, if you're out in the sunlight, your skin becomes more sensitive when you're on this medication. And just something else to keep in mind is that it stains the teeth and the bones. So you typically try and stay away from doxycycline when you give it to kids or when you give it to pregnant patients. Okay? Then we have Bactrim, TMP-SMX. So it can cause kernicterus. Kernicterus is an unfortunate condition in babies where they can have jaundice, yellowing of the skin and eyes, and they can also have some neurological side effects. It's a pretty serious condition, so that's why you avoid giving Bactrim in pregnant patients. And Bactrim is also a sulfa medication. Sulfa medications classically lead to Stevens-Johnson syndrome or SJS. Just FYI, penicillins are also sulfa-containing medications, and they also have a risk of leading to SJS. It's an unfortunate condition as well, where you have some skin sloughing. It can also affect the oral mucosa, such as the mouth, the genital region, the lip region, the eye region as well, I believe. And for this, it's just a supportive care. This patient starts having this serious rash. You admit them in the hospital, you stop the medication, and then you just treat them supportively. The final medication is Ceftaroline. So this is again our 5th generation cephalosporin. It can also cause C. diff. It can also cause transaminitis or increased ALT and AST. It can also cause hypokalemia. And then there have been some case reports of Ceftaroline causing encephalopathy. So you can have a patient who gets seizures, or they can have focal neurological deficits. Some examples of FNDs include dysarthria or slurred speech, diplopia or double vision, or hemiparesis. Basically, a patient says, I suddenly can't move or have weakness in my left arm or my right arm. It's normally isolated to one part of the body or one limb. Okay, so this is just a brief overview. And then just one correction about vancomycin. So I mentioned here there's optic neuropathy with linezolid. For vancomycin, it's actually nephrotoxic and it's actually more ototoxic. So oto and nephrotoxic, okay? Oto is referring to the ears, okay? So you can have a patient who has some hearing problems after starting vancomycin. You can have like a bumping creatinine or kidney-induced damage after you start a patient on vancomycin. So just wanted to correct here, it's more in the kidneys and in the ears. All right, so hopefully this mnemonic helped Lion to Dab in the clean pristine van and Tiger and Dog covered in tons of tar. If you have any questions, please feel free to leave a comment in the comment section below. And thank you guys so much for watching. Take care now.